Knees flex at 30 degrees.
This is our cornstarch. I did knee with him.
Cornstarch. So this is the cornstarch that we made from water and cornstarch.
You can sterilize these, right?
Correct. So
For
sterile, you still do, and like even endovaginal, anything, you still do the regular gel. But just for scanning, it's okay. Yeah. So this is the quadriceps tendon. You can follow it up. It comes from the muscle. You'll see it turn into tendon. And you see it come down. It come all the way down to the insertion.
This one is femur, right?
Yes, this is femur, and this is up here is the patella. Yeah, it inserts here. This is super. She has a little bit of fluid there. Recess. Yeah. So yeah, you can kind of squish it down and bring it back up.
Is the fluid normal?
A lot of people have a little bit of physiologic fluid there. Yours is mild. The tendon looks hypoechoic on the quad tendon insertion just because of the anisotrophy, because of the angle. Yeah. So you can come down and evaluate. And it does extend over the patella here a little bit, so you want to evaluate this area as well. This would be like your area if you have a prepatellar bursa, like the superficial bursa. So if you actually float some gel off, you'll be able to see it better.
Okay.
If you don't,
what is gel patch?
Yeah, we call it like a gel standoff.
Okay.
For anything really superficial, especially with MSK, just the pressure of the probe can compress it. From the same view, we can go transverse. And here we see the quad tendon. And again, we just follow it all the way down here. A lot of people do like this view for joint aspiration because the suprapatellar pouch there communicates with the rest of the joint. So if you have a joint effusion, it's a good place to go. You can also straighten their leg and have them like raise it a few times up and down, and then have them sit back up. And sometimes you can actually, it's like a pumping mechanism. Sometimes you can pump more fluid into it. She only has a little bit, but it is a way to confirm there isn't anything. You can have her put her knee up this way. And you want it at 90 degrees. Can you come up higher? And here's where we evaluate the femoral trochlea. So this is the distal femur. And we're looking at the cartilage. So there's the medial peak and the lateral peak out here. And basically the hypoechoic area here is the cartilage. So you're looking for cartilage thinning, absent cartilage. Patients with severe osteoarthritis, it'll be like no cartilage. But things like that could be contributing to joint pain. Patellar tendon. You come down on here on the patella a little bit. So you see here, let's increase this just to look at the tendon. The origin we see on the patella. The patellar tendon should have this like fibrous appearance. They call it like a coarse echo texture. And you come all the way down to where it inserts on the tibia. It should be similar in appearance and width throughout. So those are things we're looking at besides like an acute tear or something to see if there's any tendinosis or anything like that. When you decrease your depth, drop the football down a little bit. Patellar recess. So this is this whole area really is the infrapatellar fat pad. It's large. So patients that get fat pad inflammation, you can put like your color Doppler in there. You can also look for changes. It can get really hypoechoic, things like that. So there's like a bursa in this area here, and then there's a second bursa all the way down here. So you can see Kamani's has like a tiny bit of fluid in it, if you see there.
Yes.
So, and it's towards the insertion on the tibia. So other things I see sometimes down here is like calcium within the tendon, calcific tendinosis, things like that, yeah. And then we come back and do the exact same thing in short axis. Let's see. I got off of it. This is the tendon here. Yeah, so you can see that little bit of fluid right there.